No, thank you, Kathleen. So my brief over the next, I think, 15 minutes will be to give you an overview of our two palliative care guidelines, the pain and constipation guidelines. And because it's a short amount of time and there's a fair amount to get through, this is just a little bit of a high-level overview of where we hopefully will be going. So a few slides initially on the background, why we focused on these two palliative care guidelines. And then just, I suppose, a definition of the aim and scope of the guidelines so that one's all clear about who these guidelines are focused on. And then I'll provide you with an overview of the format of the guidelines so that hopefully you'll be able to orientate yourselves to them and know how to navigate through the documents. Unfortunately, we don't have time today really to go through the recommendations of the guidelines in depth, but we will be signposting you to an awful lot of educational resources where hopefully some of the more detailed parts of the guidelines can be examined. And what I'd also emphasise is the fact that the specialist palliative care teams that are working in partnership with the usual community, hospital, primary care services are very much there to provide an educational support wherever required. So please do make contact with any specialist palliative care team members that you might identify here today, and equally they'll be very interested to make networks and links with other people working in those other settings. And then really the main part will be just signposting to you to those resources to support implementation. So I think Evelyn has made the point very powerfully as to why we should consider both cancer pain and constipation. Her story, although unique to herself, unfortunately is one that is echoed by an awful lot of patients. 50 to 90% of patients with cancer will experience pain at some stage in their illness, with cancer prevalence becoming more common as often disease advances. And actually, more than 1/3 of patients who experience cancer pain will say that their pain is moderate or severe in intensity, so that it meaningfully really does impact on their quality of life. Not unsurprisingly, because it is such a distressing symptom, hospital admissions for pain are common, and in fact, breathlessness and pain are two of the most common reasons for patients with cancer to attend emergency departments. And despite the fact that the WHO analgesic ladder was published back in 1990 and it provides us with a roadmap for managing cancer pain, unfortunately, pain remains poorly controlled. In terms of constipation, constipation is also a very prevalent symptom. Depending on the patient's population studied, the figures can range anywhere from 30 to 90%. But I suppose one of the take-home messages for today is that 90% of patients who are on chronic opioid therapy do experience constipation. So it's almost something inevitable when one prescribes analgesics. So certainly something to think about in terms of prevention and proactive treatment. Constipation isn't only distressing because of the symptom itself, but because it leads to a number of sequelae, including nausea, vomiting, anorexia, local complications like hemorrhoids or fissures, and in the most severe cases, bowel obstruction and indeed urinary retention. Evelyn referred to the fact that people take lots of laxatives, and sometimes people aren't the clearest on the rationale or why they're taking particular laxatives, and it is actually well recognised that prescribing practice is suboptimal. Despite laxatives, up to 70% of patients in one palliative care series remained constipated. And again, it is associated with the cost. One series in the US of patients with chronic constipation, their healthcare utilisation was increased with an approximate increase in expenditure of over €2,500 per annum. So again, it's not so much a matter of these things are expensive, but it's the fact that there are effective treatments out there that if we use them, they can free up resources that we can then look to applying in other parts of the healthcare service that are stretched. So the aim and the scope of the cancer pain guideline is very much clearly to benefit patients with cancer by reducing pain and improving quality of life. The guideline isn't just applicable to specialist palliative care professionals, and I think this is a message that has got out to this room because we actually have an even split, 50-50, between people working hospital, community and primary care settings, and also then the remainder working in specialist palliative care. So the guideline is relevant to all healthcare professionals. So this can include palliative care staff, physicians, surgeons, GPs, pharmacists and nursing staff in a variety of settings. The guideline does recommend then where specialist advice should be sought in the management of particular problems. It's important to recognise that there are different types of pain, and the guideline does not apply to the management of pain in cancer survivors. A chronic pain approach is applied in those patients, to patients who do not have a cancer diagnosis or who have other forms of acute or chronic non-malignant pain. And importantly, the guideline does not apply to children. The scope of the constipation guideline is similar, other than the constipation guideline is applicable to patients with both malignant and non-malignant disease. But again, the focus improving quality of life, and the guideline being relevant to healthcare professionals working in all settings. The guideline similarly not applying to children. So a word now on the format of the recommendations of the guidelines. You'll see in the longer form of your guidelines and in some of the summary documents that much of the text around the literature has these little, I suppose, signs or notes on the right-hand side of the margin that are coloured green and that have various levels associated with them. And you'll also see in the format of the recommendations is that you have a line that designates the responsibility or who the recommendation is applicable to, followed then by the key finding. So in this key finding, the WHO analgesic ladder has been extensively validated and been shown to be effective in the management of pain in the majority of cancer patients. And that key finding leads then to a recommendation that cancer patients should have their pain managed in accordance with the WHO cancer pain relief guidance. And what you'll see next to that recommendation is a letter which will vary from A to D, and in this case is C. So what do those two signs mean? The numbers on the edge of the margin and the letters associated with the recommendation? Well, they are pieces that indicate or signpost to you the grading of the evidence. So we all know that we are trying to practice evidence-based medicine, but there are certain situations where the evidence base that we have for some practices is stronger than it is in other areas. And it's important that healthcare professionals are aware of the strength of the evidence so that they then know how to weigh this as part of their judgment or their decision-making process. So you'll see there we've used in the guidelines the Centre for Evidence-Based Medicine and the Oxford grading system, and the levels refer to the specific methodology of the trials which underpin the evidence. And you can see that they range from level 1 to level 5, with level 1 being the strongest, most methodologically rigorous, usually in the form of randomized controlled trials, and then going all the way down to level 5 evidence, where it really is evidence based on the basis of expert guidance, clinical experience. And then using those levels of evidence and then formulating them in a considered judgment approach, that then allows people to then grade the strength of the recommendation. So you'll see that a grade A recommendation is quite a strong recommendation, whereas a grade D recommendation is one which really is based on expert guidance. Now, the keen-eyed among you will notice that not always, if you have levels of evidence along the text, sometimes you might actually find that your recommendation is a little bit weaker, even if the recommendations have been made on the basis of randomized controlled trials. And that's because considered judgment has been applied. The authors have looked through the trial and they've seen how well designed it is. And even though a study may be a randomized controlled trial, it may be inadequately powered, it may have other flaws in its execution, which means that you can't actually give it a level A evidence because of that, and you might have to downgrade it a little bit. Very importantly, as a tool in terms of using the guidelines are intended to serve as part of the evidence-based process, so you need to combine best research evidence, the clinical state and circumstances of the patient, very importantly, the patient's preferences and actions, and also one's own level of expertise. So, for example, some medications are more suited to specialist practitioners, and others may be suitable for a wider audience. So you're really triangulating all of those pieces of evidence and consideration when you are applying the guideline. And importantly, when you're using the guideline and you're applying your clinical decision making, don't forget to document your decision making process in notes. A final point about the format of the guidelines, you'll see that there's a best practice point about pharmacoeconomics, where there's no evidence of a differential benefit between different medications in terms of efficacy, tolerability, or side effect profile, and where clinical expertise allows the medication with the lowest cost base should be used. It sounds very simple, but Professor Phil Larkin will be talking a little bit later around the point prevalence study that we've been conducting. And while we don't have full analysis of the findings as yet, it may not come as a complete surprise to you that actually the cheapest opioid is not the one that we use most frequently. So again, evidence, room for us to start freeing up resources to use in other stressed areas of the service. So this gives you a little bit of an idea around some of the guideline recommendations. In this particular recommendation is about selection of opioid, and it brings to that point around the importance of choosing your opioid. And what the evidence will say is that morphine, oxycodone, hydromorphone and methadone all have similar evidence bases. So therefore they are all valid choices for patients with moderate to severe cancer pain. But in situations where where patient factors are such that there is no particular preference for one opioid than the other, then morphine sulfate would become the opioid of first line choice because of reasons of cost. So morphine sulfate, hydromorphone and oxycodone are all valid first line treatments in the management of moderate to severe pain for patients with normal renal function. When all other considerations are equal, one would suggest that one would start with morphine, but what needs to recognise is that these medications are associated with side effects, and about 1 in 4 patients will be sensitive to your first line choice of agent, so you may well have to switch to an alternative second line opioid in order to ensure tolerability. This then is the recommendation about renal impairment, which shows that in patients with moderate to severe renal impairment, particularly those patients with an eGFR of less than 30, one shouldn't use morphine, oxycodone or hydromorphone as an opioid of first choice, but one should seek specialist advice wherever possible, and the specialist will usually begin treatment with fentanyl or alfentanil as an opioid. Looking towards constipation, some of the recommendations here lie around the key finding that a comprehensive assessment is required to accurately diagnose the presence and potential causes of constipation in patients with life-limiting illness. It sounds a very straightforward recommendation that a thorough history and physical examination are recommended as essential components of the assessment process. But actually, what we found in Audit is that physical examination often isn't done for patients with constipation, and histories are guide treatment. So the guideline does talk about the important role of a digital rectal exam for those patients in which it is necessary to exclude fecal impaction. And it makes an important recommendation about the limited role of plain films of abdomen. So PFAs aren't particularly helpful in routinely diagnosing constipation. The reporting error margin is wide. And so what we are saying is that history and examination is your best first line approach. So moving now to the resources that support the implementation of the guidelines. You'll see here we have a suite for the cancer pain guidelines, and there's examples of them on your tables. There's a patient information leaflet, and then because the guideline is a large guideline and it's difficult to digest it, we've started producing a number of quick user guides and hope to produce more going into the future. So you'll see a quick user guide, which is a smaller leaflet that tells you how to initiate and titrate opioids. There's a quick user guide on the use of opioids in renal impairment and in liver failure also, because those are two challenging situations that commonly arise in practice. There's also a poster that we've produced which tries to summarize things around WHO ladder, initiating and titrating opioids, and actually managing opioid toxicity. And again, also switching between different opioids and having conversion ratios. So again, a useful point in practice that was designed really to put up on pharmacy doors or ward doors to try and help. Very importantly, one of the most significant things that have been shown to impact on the implementation of guidelines is the delivery of multi-component education over time. So we're beginning our journey in terms of providing educational resources. There's a PowerPoint presentation available on the NCEC website, and then two short e-learning modules, each less than 10 minutes duration, on the learning platform of the All Ireland Institute of Hospice and Palliative Care. And that website is freely accessible there once you register at the institute on the web address there. Constipation has similar resources, although because it's a slightly more straightforward guideline, we haven't produced quick user guides, but you'll see the variety of education on patient information leaflets and also a cartoon for patient education around constipation. And then finally, as a resource, I want to point to the importance of audit. And I've put bells and whistles and flashing signs for audit because unfortunately everybody's minds glazes over when we talk about audit. We'd like to think that audit was a rocket that was taking off and pushing the healthcare system further forward, but unfortunately it's a rocket that hasn't really taken off the ground, and audit, generally speaking, isn't established in clinical practice. Maybe to try and help us think a little bit and rejuvenate our enthusiasm for audit. If you think about Florence Nightingale over 150 years ago, she kept mortality records during the Crimean War, and it was on the basis of that data collection, looking at practice, looking at standards of practice, reviewing how things were going, the precursors of audit, that she realised it wasn't the war injuries, but rather it was the sanitary conditions that were responsible for the death of thousands of soldiers. Before that, that had not been recognised. And I think Florence Nightingale spoke very powerfully in one of her correspondence where she said, the main end of statistics should not be to inform government as to how many men have died, but to enable steps to be taken to prevent the extension of disease and mortality. And so that's what we need to think about. We need to think about audit not as a bean counting exercise that just ticks a box and counts how many patients get something or don't. What are you going to do with your information? How are you going to generate change? So one of the more modern definitions of audit is it's the systematic review of care against explicit criteria or standards, but it's the implementation of change that we need to think about. So we've produced two audit guides, which really try and make audit as easy as possible in that they're Excel sheets with your standards. You have your criteria against which you audit. There's drop-down boxes, and it even auto-calculates your scores at the end of the process. So I'd very much direct you to look into the audit tools. So they're very much a whistle-stop tour across the guidelines and the resources. These are our only preliminary ideas about implementation. Today really is us going to be sharing our collective knowledge and experience. So I would say at this point, all ideas to support implementation are welcomed. We'll collect them, I'm sure, as we're going around the tables. But if anybody has any bright idea, and quite literally, bright ideas can originate. We heard at the National Patient Safety Office conference the other week about an NCHD who was challenged by communication and WhatsApping between NCHDs and has gone on to develop a secure communications device that really is taking off. So it just goes to show, ideas really can affect change. So I'd like to say thank you to you for your patience, but also very much to the team behind the production of the guidelines, too numerable to mention, but particularly the guideline development groups, the clinical program working group, advisory group, the library, program managers, and of course the National Clinical Effectiveness Committee and the National Patient Safety Office. Thank you.